I'm Dr. Geraldine Brosfield. I'm Exo Health, along with Kirsten Foster, who's my patient navigator, who's with us on the call today. And welcome to the webinar today about the 6 types of Alzheimer's. We're going to discuss some of the research that's been going on over the last 30 years to learn more about this disease and to help people really know ways that they can take charge of their own health and make a difference in their health trajectory. When we've talked before, some of you have heard me say that one of the things that many of us fear the most in life is losing our mind. And I don't know of anything that's more impacting than our mental and cognitive function. It's absolutely imperative, obviously, to enjoying life and doing the things that are important to us. And so we're going to talk about that and the current crisis around Alzheimer's disease and what we're going to be able to do about it because of new and emerging research. I'm going to share my screen so that we can use a PowerPoint as we go through this. And any of you who are members at Exo Health should know that this information is accessible to you through our office. And also, if you are a friend of ours on Facebook for Exo Health, you can find these webinars archived there as well, so that you'll be able to access this information in the future. I'll have a time at the end of our conversation to take questions, and certainly if you're interested in pursuing this kind of testing for yourself or this whole discussion, know that that's exactly what we do in our office with both our memberships and our cognoscopy testing. I'm going to switch over now and so that you can see my screen. Just a moment. Okay. So the 6 types of Alzheimer's disease is our talk today, and many of you may know that when you go to your doctor, you may ask them about something that you've read recently in the paper or some emerging research that's been reported on. And I often hear, and I think it's very common, that we go to a physician and they maybe don't know about the question that you're asking. It's not something they've heard about. And I just want to say that if you gather this information that we're going to talk about today and dig in and learn more about it, you may actually be more well-informed about Alzheimer's disease and Alzheimer's research than your own physician. And I just want to encourage you to not let that stop you. That just means that your doctor is very normal, and the dissemination of information, when we find something new in research in our country, unfortunately, is 17 years before that research finding makes its way out into communities as a standard of care. So what we're talking about today is cutting edge information. It's brand new, it is emerging, and it's changing. And I'm going to point out a couple places along the way where it's changing over this past year in new and exciting ways. The scope of the issue with Alzheimer's disease is that this is an increasing issue in our population. Right now, there's 5 million patients with Alzheimer's disease as a diagnosis, and we expect that number to more than triple over the next 30 years. So when we look at those numbers and we say, okay, we have a rapidly increasing diagnosis that's extremely debilitating. 65% of Alzheimer's patients are women, and in fact, 64% of caregivers are women. And then 1 in 3 of our seniors die with a diagnosis of dementia. You know, if you think about the scope and the cost to our system, not only in dollars, but really in loss of human creativity and human vision and human capacity, it's just profoundly impacting. And so the Alzheimer's Association of America has said our vision is a world without Alzheimer's, and I fully agree. And I will say that the work that we're going to talk about today is the most hopeful new work that I can see on the horizon around the diagnosis of Alzheimer's. I'm going to review a couple things that have been our current way of looking at things so that we have a framework to talk about this. Currently, we think of aging including some natural changes over time, and that it may be normal for people to have slight cognitive change over the lifespan. I want to challenge that and tell you that that's not necessarily fact. There are a lot of things that we think of as normal, but that doesn't mean that they're supposed to be normal. In other words, they may be common. Lots and lots of people have loss of memory as they age, or have a mind that they feel like is less sharp as they age. But the question is, even though that's common, even though we've come to accept that that's what's going to happen, I want to challenge that belief and say, we have no proof that that's necessary or normal. And in fact, we have proof to the opposite in the blue zones around the world where people live longer without cognitive decline. And so if we look at a natural trajectory, this is what's common, but I want to tell you it does not have to be normal. So, and I'm going to just mention, if you think that your computer is not on mute, you can look at the lower left corner of your screen, and it has a little microphone that you can click on, and it will mute you so that we don't hear the conversations around you wherever you are. Thank you. I think somebody's got a phone call that we need to just have them mute as well. So if we look at the typical expected progression that we think of as normal in the research in our country, we think of cognitive decline in a stage that's called preclinical or subjective. And what that means is the individual might notice changes. And in fact, and I'm going to just ask again if someone can mute themselves if they were on the phone. The preclinical phase is actually, we call it a silent phase. It's a phase of time where changes might be happening that we might notice in ourselves, but nobody else would notice, and they're undetectable on a test. So I often have people coming in questioning whether it's normal that they're forgetting why they went to the next room, or they're having a little bit of a harder time organizing their life than they used to. And there certainly are a lot of changes like that that happen when our minds are overloaded, when we're not focused on what we're doing, when we're trying to multitask too much, and when we're deficient in nutrition or micronutrients in our system. That preclinical phase can last for many, many years, and it shifts into the next phase, which we call MCI, which is mild cognitive impairment, when changes are testable. In other words, we can actually do a test and we can see that maybe the person isn't drawing or writing as well, or they're not answering questions as quickly. But those changes in the mild cognitive decline region are really mainly on tests, and generally only one thing is starting to not seem right to the person. And so the person in mild cognitive decline is really capable of still living alone, managing their life, driving, doing most normal activities. And that diagnosis shifts into a diagnosis of dementia when daily activities are impacted in 2 or more ways. So if the person is now having memory loss plus organizational difficulties, that they're not safe to live in their own home, or they're no longer able to do things like pay bills on the computer and they were before. Those are the types of things we start to see as the diagnosis of dementia comes into really being how we would label that change. That terminology that I just spoke, this subjective cognitive impairment, which we think of as preclinical, there's no sign of it that we can test in a clinic to say that's happening, then transitions, we believe, into mild cognitive impairment, where tests can detect an issue. And then dementia is really the label that's used when activities of daily living or work are now being affected. So this has been the paradigm or the view that we've been working with. And we've thought that in current perspectives within neurology and within the United States, if you were to go to the Alzheimer's Association or talk to a physician about Alzheimer's, this would sort of be the extent of what we know. This is a scenario where we would say, okay, within cognitive decline, these are the main issues. We see Alzheimer's disease as one issue. We see vascular dementia as affecting about 1/3 of patients, and then some other causes like Parkinson's and other neurologic disorders really impacting patients. But I want to move to thinking about what are the pieces of the puzzle that we've thought were the main impacts of those diagnoses. We've thought it really was dependent on genetics. This is the genetic test, Apo E4. This is the genetic test for Alzheimer's. And there are 2 copies for each of us in all of our genetic pool. We get one copy from our mom and one copy from our dad for each of our genes. So the Apo E4 gene, we can have one copy that's working fine and one copy that's not working. And in those cases, we have different risk based on our genetic inheritance. So where I just want to focus here is that if a person has one copy of Apo E4, and that's going to be a test, their results might look like something on a lab slip that would say Apo E3/4, for instance, would be one copy of Apo4. That conveys a 30% lifetime risk and is really the biggest risk in our population. About 75 million people have one copy of Apo E4 in the United States. If you have two copies of Apo E4, you have a much higher risk, and there's a lower part of our population that has that high of a risk. But this Apo E4 gene is interesting because it definitely means the person is more susceptible, but it is not a damnation. It does not mean they are going to get Alzheimer's for certain. And in fact, where we're going to end up our discussion today is about what you can do and why knowing your Apo E4 status is helpful to you, because it actually starts to help guide very specific therapies. Depending on your Apo E4 status, for instance, I can help guide you whether you should be ever on a ketogenic diet or not, for instance, because of the way your body would metabolize fat. So we're interested to know this status, but the limitation within traditional medicine has been we've only thought there were two things to deal with Alzheimer's. One was this Apo E4 status, and unfortunately, most neurology perspectives have been that there's nothing you can do about it, and therefore it's almost like it's background information. We know it's an impact, but there's nothing you can do about it, has been what most of my patients have been told in the past. But I'm going to try to challenge that notion. And then the other thing is that the other main issue that we've thought was the concern with Alzheimer's has been plaque in the brain. So protein deposits of a beta amyloid plaque has been our main framework about Alzheimer's. And so all of our research from the drug companies has been, they were trying to figure out a way to make that beta amyloid plaque get dissolved in the brain. And the person I'm going to speak about, Dr. Bredesen, likes to use this analogy. He says, this is like a barn with 36 holes in the roof, and the plaque in the brain is only one hole. It's only one problem. So if we fix that problem, we still have 35 holes that are going to let rain into that barn. So the traditional approach has been very lacking from the standpoint of not addressing all the issues. So I'm going to shift to what's changed, what's the new perspective, what's going on that we can now have hope that there's something we can do about this disease. This is the preliminary perspective that's impacting not only the research at UCLA that Dr. Bredesen is doing, but also MIT. Our researchers there have been finding this. In fact, NPR reported on this recently. And we're finding that Alzheimer's disease is a protective response to three major dysfunctions. And the major dysfunctions are in the realm of inflammation, or withdrawal of the growth factors that our body is supposed to have to nourish our brain, or exposure to toxins. And so the brain protects itself from these impacts, and in that protective response has done what we have thought was abnormal, but in fact maybe was a really normal protective response. Other causes of loss of memory and dementia are vascular insufficiency and traumatic injury, and those get labeled Alzheimer's, although they have different mechanisms of cause. And so I'm going to go into those for you as well. I'm going to use the approach as we talk about the 6 types of Alzheimer's, the approach that Dr. Dale Bredesen has outlined. And if you've read the book, The End of Alzheimer's, I want to just let you in on something. What I'm going to go over today is what Dr. Bredesen has researched since the book was published. So it includes parts of what are in the book, but the book actually does not have all 6 types of Alzheimer's outlined, because they did further research over this past year and have now really clarified more around the 6 types of Alzheimer's and the 6 causative pathways to Alzheimer's. So when I was at the training with Dr. Bredesen this fall, in the fall of 2017, what was amazing was just this energy of hope and excitement that was going on because the research is not done. We're continuing to find more information that shows us better and better how to treat Alzheimer's and how to prevent Alzheimer's. And so even the data that we're talking about when I say that there are 6 types of Alzheimer's is an addition to what's in Dr. Bredesen's book, The End of Alzheimer's, that was published last September. So this is the hope that has been put out both as a theory and now as a proven evidence-based protocol in treating Alzheimer's, and that is that cognitive decline associated with Alzheimer's disease can now be reversed, and improvement can be sustained by using a personalized program that is targeted to the underlying pathophysiology. Pathophysiology just means dysfunction. So if we look for what's dysfunctional, what's there that needs to be removed, and what's missing that needs to be added, we can actually reverse cognitive decline that's associated with Alzheimer's disease. So the path to that outcome is actually to look for all of the subtypes and contributors to Alzheimer's disease. And that's why, even though in some ways someone could say, well, what's important about understanding that there are 6 ways to have Alzheimer's develop, or that there are 6 types of Alzheimer's? The reason that's important is that's the beginning platform to break down what you need to do to reverse the process. So when we know what the cause is, we can then go back behind that, and this is the functional medicine approach, is to look underneath the cause and say what caused it and what do we need to do to build health so that the system can remove that problem. So one of the principles of this new approach is to say we do not try to reduce plaque. We do not remove amyloid plaque until we've identified what it's protecting the brain from. We need to know, because if I start to dissolve plaque and it's hiding and holding on to a whole bunch of herpes virus, for instance, and all of a sudden we dissolve plaque and it allows the herpes virus to be loose in our brain, we would have a worsened situation than we started with. So we have to really be careful in understanding what's the cause of this response of the brain to protect itself. And when we remove the cause, then the body can heal. So there are 6 subtypes of Alzheimer's disease, and most of us would have, if we lived long enough, most of us would have contributions towards dementia from more than one subtype. So in almost all cases, a person coming in with either the beginning parts of cognitive decline, or if we're doing this testing in someone who has no symptoms of cognitive decline and is just being proactive and getting their cognoscopy as a preventive test, we're going to see where the weakest links are, where they might eventually have issues. So we typically will find one subtype that is the main subtype for people, and then usually there's a second subtype that's a moderate contributor, and sometimes there's a third that's very minimal that we have to clear up, but usually it's 1 or 2 subtypes that we are dealing with. Obviously, the earlier the treatment, the better. The less healing there is, the easier and faster it is to see results, or the less healing that's needed. And it generally takes 3 to 6 months before we see improvement. So when we come in and when we start treating patients around brain optimization, what I say to people is we have to realize this is a long-term relationship. This is not something that's one and done. The testing, doing a cognoscopy, that can be done in 2 to 3 visits and a whole bunch of tests that get run, and then we have a picture of where we're at. It's what we do about that afterwards that takes the 3 to 6 months. And I just want to make a note. Many people will say to me, well, I've had those labs and they were within normal, about a lot of their lab tests. And I want to just say that what we're doing in this whole process is not about normal. None of us wants to be only normal. And none of us wants to be average. All of us want optimal health, want our personal best. And so even though you may have been told that your vitamin D, for instance, is within normal limits, that's what WNL stands for. Within normal limits is a bad word in my vocabulary, because it means that we have not identified what's best for that person. So we want to optimize every one of your vitamin absorptions, your dietary approach, whether or not your body's able to use the things that you're taking in. And so we are not just looking for a barely normal kind of a result. We're looking for results that promote health. So the 6 types of Alzheimer's, I'm going to go through those with just a brief description of each one, because I think it will help you understand how the treatment can differ for Alzheimer's disease. And it also starts to develop what the treatment looks like when we know these types. So type 1 Alzheimer's disease is called inflammatory. And I've put some descriptor words there. Hot is another one. Just imagine a really inflamed joint, how it gets hot and red. That would be the way you could visualize your internal body functioning when there's type 1 Alzheimer's disease. If you're an Ayurvedic specialist, this is called pitta, and it just means hot and revved up in my simplest Ayurvedic understanding. So when a person has inflammatory type Alzheimer's, we're going to see inflammatory markers that are elevated. And on the cognoscopy testing we do, we have about 8 of those that tell us more information about why the inflammation's occurring. And so we test that hsCRP for blood vessel inflammation, and then a number of other markers to say where else is this inflammation impacting the body. Apo E4 is a risk factor for this type of Alzheimer's disease, and most often this type of Alzheimer's presents with memory loss as its first finding. So our treatment for this type of Alzheimer's disease is to look for the cause of inflammation. It's one of the reasons there's a huge adage in functional medicine that says treat the gut, because it's the #1 cause of inflammation in people. This could also be caused by infections or by poor diet or by oral hygiene issues. So we look for the cause of inflammation and seek to reverse that, and this issue will then decrease its impact on the brain, and the brain will start to be able to function again. Type 2 Alzheimer's disease is cold or atrophic. And if you're again looking at Ayurvedic terminology, this one would be called vata. Now, cold or atrophic Alzheimer's disease is a presentation that tends to occur a little bit further on in our lives. It's more prevalent in our 70s and 80s, and people do present with memory loss, and often the patient thinks there is no memory loss. The main cause behind this atrophic type of Alzheimer's disease is removal in body nurturing of its own hormones and its own enzymes. So vitamin D is in this category, which is a very simple, thing to change from the standpoint of either getting sun or supplementing vitamin D to appropriate levels. We try to get that vitamin D between 60 and 80 on blood testing. Hormones, which are controversial, certainly, and so there's a full discussion around the risks and benefits of what way to present hormones back into the body if that's needed. Reduction in thyroid, pregnenolone, which is another supportive metabolism hormone, will often be depleted. And I sometimes see pregnenolone as sort of a side impact. Like if thyroid is functioning fairly, pregnenolone will be telling us that it's struggling, and we'll start to supplement there, and then it'll end up trickling over to thyroid and helping that system as well. BDNF is brain-derived nucleatic factor, and those are hormones and enzymes that really impact the brain from the standpoint of regenerating brain tissue. So the word trophic and atrophic means shrinking or shriveled up. Trophic means providing support and nutrition and supplementation. So it's as if as we age, some of our systems and our hormonal systems will run out of gas. They don't continue if we've stressed ourselves our whole life. And so those symptoms can be, those systems can be rebooted, and the symptoms then usually resolve as we retreat the brain with all the nurturing factors. This type 1.5, was added as a supplemental type later because, as you can imagine, if you had already named types 1, 2, 3, 4, 5, how are you going to go back and appropriately label this type? And it made more sense to call it type 1.5 because it's a combination of type 1 and 2. So we call this glycotoxic or sweet type. It's a combination of inflammation and atrophic change. So the way that works is if the inflammation is happening because this person has insulin resistance, they have had high blood sugar impacting their body, that blood sugar has done a bad thing called glycosylation, which means clumps of sugar or clumps of rusted cells in the body because of the constant sugar exposure. That inflammation is part of the problem, but the problem then is that your body, even though you've been making lots of insulin, no longer has receptors for insulin. It's insulin resistant. And if the body is insulin resistant, it then falls into that atrophic type 2 of Alzheimer's, because the brain is literally not getting the nurturing that it needs with low normal insulin, with vitamin D, with all of the other enzymes that occur when we're insulin resistant. So this is that combination. ApoE is again an important risk factor for this type of Alzheimer's, and memory loss is presenting. So type 1, 1.5, and 2 all have Apo E4 as an important factor in what causes the predisposition, and they all present with memory loss as the main presenting symptoms. So in this case, in order to reverse this glycotoxic type of Alzheimer's disease, restoring insulin sensitivity is the #1 goal. And then we do the supplementation so that we manage the atrophic changes, and we work with diet and removing any inflammatory causes as well. Type 3 is one of the newer kids on the block, if we want to call it that. And in this case, Apo E4 actually may protect the person from developing this kind of Alzheimer's. So it is not caused by an Apo E4 mutation. You may be protected from this type if you have that mutation. This type tends to present much, much younger, like late 50s and early 60s is more common. And the toxic type of Alzheimer's is really something completely different. This is literally as though the brain was exposed to poison. This type of Alzheimer's became much more well known in the research because within the 8 to 10 years after 9/11, we started to see a prevalence and a big increase in early onset Alzheimer's in women and men's 50s and 60s. And what they found was that there was significant exposure to the dust cloud in Manhattan that predisposed a large group of people to this type of Alzheimer's because of the inhalation of that dust cloud. So this type of Alzheimer's is a little bit more tricky. I will tell you, if this is the type that ends up being the predominant type for my patients, I'm partnering with 2 or 3 other experts in this field because detoxification from this severe of a toxin is a real difficult problem. We have specialists. There's 2 in Southern California. There's another program in Pasadena that it does great jobs with detoxification, and we'll partner for this portion of the care because it is tricky. Many times this is due to mold exposure or virus exposure. And so if it's not an inhaled toxin or a pesticide type exposure, then we're looking at, and here in the office, we've started doing a lot of mold testing in people's environments, as well as viral testing to see if the body still has a heavy load of virus from the time we had mono when we were 16, or an Epstein-Barr virus infection, or herpes, or Lyme's disease. So we're finding that this is present when people least suspected it. Many people do not come in thinking they have this type of Alzheimer's, and when we find it, we're a bit surprised. But the good news about this type of Alzheimer's is when you remove the toxin, the person gets well. So the biggest hope has been in some of these patients that have had this devastating early onset Alzheimer's disease that was because of a toxic exposure. And when that detoxification occurs, their brain starts to work again, and it's miraculous actually to observe. Type 4 Alzheimer's and type 5 are the 2 that we've known these labels in the past, and we've lumped them into Alzheimer's disease as a diagnosis, but they also have somewhat different causative factors. Type 4 is not an Apo E4 disease typically. This is a vascular type of Alzheimer's disease where the blood flow to the brain has been compromised. And so if you imagine just literally not getting oxygen, that is really what's behind this type of Alzheimer's disease. It's an oxygenation and blood vessel supply issue. And you can imagine also that if vascular flow to the brain is impaired, you're also not going to get all the nutrition to the brain that needs to get there, whether that's vitamin D or coconut oil or all kinds of things that you might be doing that would be good. It's just as if the delivery system is really impaired, that will cause significant loss of function. And we know that if you, in a very simple way, think about cardiovascular disease, we've come to understand the concept of blockage in our arteries and heart disease. And in many ways, that's the same issue here with Alzheimer's disease, in that if you have blood vessels that have a real significant thick buildup of plaque in the blood vessels, you're going to have impaired blood flow through those vessels. And so particularly if we're coming out with a diagnosis of vascular Alzheimer's disease, we want to be looking at the same time at the cardiovascular disease and treating both, because the mechanisms of that change may be very similar, and actually we can create brain health and heart health by reversing those processes. And so even though some of the statements here as the last line on these slides seem really obvious and almost so simply stated that they seem ludicrous, like improve the blood flow. Well, of course we would improve the blood flow to the brain. How do we do that becomes the question. And what I'd like to posit is that the way we do that is creating whole system health. When we alter the way that cholesterol, for instance, is metabolized and help it not build up in the arteries, we then improve blood flow to the brain. When we look at things like adding hormones back in, we allow for the blood vessels to be elastic so that they can expand and stretch and contract when they're supposed to, and that improves blood flow to the brain. So none of these approaches there's not one thing that fixes all of them. They're all what we call multifactorial and require treating all of those causes to improve brain health. Type 5 of Alzheimer's, this is the last type, is traumatic brain injury. And another term that, just to help you remember that, would be dazed. So this is very typical, for instance, in our football players or in people who've had multiple concussions. And it can present at any age. I mean, this can occur very young or very old. And it is not a genetic factor that implicates this. This is really actually because of shaking the brain up too much. One of the things that's been profound, and there's lots of research on this, this is a topic we could go into in depth in and of itself, is what is functional brain therapy? There are incredible therapies right now between neurofeedback, electromagnetic stimulation, TMS, transcranial magnetic stimulation, and even a bunch of things that are so wild and woolly that I can tell you I've seen videos and they look amazing, but we would have to look up even who's doing them. Things where by stimulating the tongue with a mild electricity, kind of like when we used to lick the batteries, but that stimulation at the back of the tongue will reset neurons in the brain after traumatic brain injury. So there are lots of research being done in this area. There are a lot of approaches, and I've seen incredible results with these types of treatment for brain injury that then bring back brain function. So when we talk about how do we reverse any of those types of Alzheimer's, we treat every identified abnormality. If we provide support for normal brain function and we remove the things that are harming the brain, we start to see the progression of brain decline stop. And it literally is that as the body's biochemistry changes, cognition changes. So if we improve the biochemistry, we have better cognition. If our biochemistry is not functioning well, our cognition goes down. And so one of the terms that Dr. Bredesen has coined and we're providing is the cognoscopy. And the cognoscopy is a set of visits with a healthcare provider. This is what I do in 2 to 3 visits, where we do a number of in-depth history questions, as well as, sorry, my phone or my screen may be doing something strange here. I'm not sure if I'm in or out. Did you just lose me? I can't tell if you can hear me. Can you raise your hand if you can hear me? Okay, good. I couldn't tell if there was an issue with my Zoom not being connected or not.
You're back to the 6 types of Alzheimer's.
Thank you. I see that we lost the slide I was on, and thank you, Ralph, for telling me that you can hear me. I'm going to just come back here then to, there we go. Maybe that's better. To treating every identified abnormality. We do the cognoscopy to find out where the abnormalities are. And when we do that cognoscopy, it includes 40-some blood tests. Some of those are genetic, others are metabolic, and many of them are inflammatory or very specific to figure out what is going wrong and which subtype the person really has so that we know how to guide the treatment. That testing really forms the platform that then allows us to choose which subtype is the main issue for the person. And so once we know from that testing what subtype are really the most profound issues for any given individual, we can then optimize brain function by optimizing and healing that subtype. So as I mentioned, the cognoscopy, just in case you're trying to say, well, what am I going to do when I do it? Literally, the first visit is a long talk. It's a lot of history questions. And then we set up a lab test that you go to a lab, and you can't do this at every lab. Many labs do not do all of these tests. So you need a physician who's created relationships with laboratories that can do the tests. We do those tests, we come back, we do some questionnaires, and then we get those results and we go over them together. That process is not fast. People get frustrated because we're waiting for blood tests for about 4 weeks to all come back from all the different labs across the US. But after 4 weeks, we can go over those together and we can identify the areas that are abnormal that we need to start working on. So what do we do then? We treat all contributors and deficiencies, and I say that as the understatement of the century. But in essence, it really is removal of any toxins, removal of any abnormalities, and then supplementing with the things on this list: a low inflammatory diet, targeted supplementation, exercise, sleep and stress management, and social support and stimulation all need to play a role. The part of the work that I think maybe is the most intense for any given individual is optimizing their diet to what they need. There are at least 3, if not more, certainly variations on dietary approaches that then can be specified for the individual. And targeted supplements are used to very specifically clear up deficiencies or work around genetic blocks that have stopped the person from being able to detox their own system. So we tend to do the work in our office around the low inflammatory diet and the supplements, and then work with partners to help you with exercise programming, stress management, or other functional brain training if that's needed. So I just want to encourage you that the then what is a journey. That's a process of lifestyle change and very targeted medical therapies to the subtype that the person has been identified to have. And I hope that by knowing the subtypes that we've talked about today, you are more well prepared to go search the information you need to prevent brain decline in your own life. And we'll continue to be here at ExoHealth for questions, and welcome you if you'd like to come in to have a cognoscopy or a visit in our office. I'm going to come back to all of us here on the conversation and open it up for some questions for about 10 minutes before we end at 1 o'clock. If you want to ask a question, just notice that at the bottom left of your screen is a little microphone that says mute, and if you're muted, it will have a red line through it. So you need to click on it so that you don't have a red line through it if you want to ask a question. And another option is you can type a question into the chat box that's at the bottom of your screen as well. So I'd be happy to answer questions if I can. And certainly if the questions are personal in nature, I'm going to refer you to making an appointment so we can talk about things that are a little bit more personal, but would be happy to answer questions that may help everybody learn more. One of the beauties with Dr. Bredesen is that his protocol has been to start developing a software that if we load in all of the information that we gather in that cognoscopy, we can actually get a report back from Dr. Bredesen, and you can, I can work with you to sign up to have that report come back that gives you his perspective on which type is your main subtype and which are the contributing subtypes, along with recommendations about what to do for each of those. One question that's come in the chat box is, how can we absorb vitamin and minerals better? What can we do to know if those are working? So that's where I really invite you to partner with us to know that information. When people, I'll give you an example. When people, for instance, get a B12 shot at their doctor's office, we often think of that as this much better way to get our vitamins and minerals in. And the tough thing about that is you may not be able to get the vitamins out of your bloodstream out into your tissue. And that's genetically determined or nutrient determined. If you are deficient in some of the carrier proteins or the pathways that allow you to absorb a vitamin, we could put a whole lot of it in the blood vessels, just like loading a freeway with lots of delivery trucks. But if they can't get off the off ramps, they're not getting into the tissue. So the best way to know if you're absorbing vitamins is really to have some specialized testing. And unfortunately, it's not blood testing at a routine lab. It's not just getting a B12 level checked, because the B12 level that is checked on your blood, for instance, is just testing how many trucks are on the freeway, for instance. It's just testing how much B12 is in your blood, not whether it's being used by your cells. So there are several tests from reference laboratories. Reference laboratories are labs that focus in on one specific type of area, like metabolism or vitamins. And so I will often do urine tests that tell me whether or not you're absorbing and getting the vitamin B12, for instance, to your tissue, so that we can know if the route and the method you're taking it is working. If it isn't, there's a problem and we need to adjust that. So I will tell you that is a little bit of a, that's a search. That's one of the things I do a lot in the office, is checking to see if the person is absorbing their nutrients. And if they're not, then we work with the body to increase absorption by optimizing the digestion. Chris, thank you for your question. Is it ever too late? What if there's another issue, like a treatment for cancer? You are absolutely right on in the complexity that your question is inferring. It's not ever too late, although I will say that, for instance, in Dr. Bredesen's studies, he's had people with testing at a score of 0 on their cognitive tests. So there are several tests that we do. One, some of you may be familiar with, called the MoCA, where you're drawing a clock on a paper and you're remembering the words camel and lion and a few other words. And that test gets scored. And if a person has a score that's less than 10, they are severely impaired. And in Dr. Bredesen's studies, he's had people with a score of 0, which means these are people who are non-functional and really requiring help 24 hours a day. Those patients have had results where they've improved and their function has come back to some degree. I think the question of, is it ever too late, is really more around whether or not we can get back to cognitive change or cognitive function that's back to what we think of as normal. Dr. Bredesen has seen improvement in every person following the protocol. The improvement in how much, like how do you get back to the bar of, being able to function in day-to-day life, is really determined by how late it is. If we're further along, it takes longer to heal, and the question is kind of how far back can we come? But everyone has improved on the protocol. To the extent, I was actually shocked at this statement from Dr. Bredesen. He said, if your patient is not improving, you've missed something. And that's a pretty profound statement. That means he has 100% confidence that every person, when he's gone back and looked at the non-improving patients, he's found something else that could be improved and they've been able to improve. Your second part of your question, what if there's another, another health issue like cancer, does very much get tricky. I'll say the same thing is in the realm, for instance, of hormone replacement. I have some patients who don't want to go on estrogen because of breast cancer, and that's a long discussion because actually estrogen is not causative of breast cancer, but it is thought to be that in most of our oncology community. And so we have to have some really extensive discussions about that and sometimes do some second opinions. With treatment for cancer, in some ways it becomes really a very personal decision from the standpoint of whether the treatment for cancer precludes us from doing the brain treatment. In other words, some oncologists don't want us to treat with vitamins when they're doing chemotherapy because they want the cancer cells to get starved. The problem is we're starving the whole system, for instance, of nutrition. And so it becomes a bit of a dance, I would say, working with your other providers if there's a treatment of cancer going on, because we have to make decisions about what the priorities are and whether we can go ahead and choose, for instance, to nurture the body and not cause harm. But in all, I will tell you, it becomes a very sometimes difficult, long discussion of navigating, but worthwhile from the standpoint of saying if we can optimize the body's health, we then also help the body fight off the cancer. So it just becomes tricky to do it in the realm of some of these other diagnoses. I think we have, I'm guessing because I keep seeing Carrie on here, I think we have Mexico represented today. It's nice to see you where there's a breeze and some bougainvillea behind you, Carrie. Are there any other questions that someone would, oh, beautiful. I see you. That's gorgeous. Look at that water. I can't hear you because you're on mute. Let me see if I can. I don't think I have that power to change it. It's so nice to see each of you on here. And I know those of you that are starting to get more familiar with Zoom are starting to see how we can see each other on this in this format. And it's nice to be able to see each other. I invite you to continue to dialogue about this topic. You know, the 6 types of Alzheimer's are meant to just be an overview so that you start to get a framework of how we can look at this disease and how we can break it down. You know, one of the ad nauseum old favorite sayings that, you know, I use over and over is, how do you eat an elephant? One bite at a time. I think of Alzheimer's maybe in that way from the standpoint of it's taken the 30 years that Dr. Bredesen and our other researchers have been doing to come up with a format that allows us to break the treatment down into something that's not only effective, but simple to understand from the standpoint of breaking it down into small pieces, into one bite at a time. And so I think that if we look at even simple things, and I say this because vitamin D comes up day in and day out, even simple things like our vitamin D, which Carrie, you've got some right behind you, so I'm so glad you're where you can get into it. But sun exposure, for instance, or helping our body make vitamin D is one of the simplest things we can do for ourselves, but it's one of, you know, many, many things we can do. And it's dialing in which of those we need to do that I really invite you to partner with me to do or find someone to help you with. If you're not getting answers that are satisfying, keep looking. And I don't mean that to sound trite. I just mean that oftentimes every one of us as doctors has done training or has a certain set of knowledge. And if your physician or your healthcare team isn't knowledgeable about this, keep looking, because there are answers. And I want you to let me know if you want to get in and get an appointment. We'll work to get you in. But I just encourage you to not give up, because there's incredible hope on the horizon in this realm. And I think we all absolutely have options now that have never been available since they really started in 2014 with Dr. Bredesen's first publications and knowledge around how to treat this disease. Thank you so much for being with me for this hour. I appreciate it. Join us again at 12:10 next Wednesday, and we'll be talking at that time about another topic that's pertinent to your health. So thank you. I'm Dr. Brosfield at Exo Health, and our phone number here, if you don't have it, is 760-573-2761. Thank you, each one of you. Have a good rest of your Wednesday.
Thank you.